Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, a neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of lectures of Prime Neurology. There are totally 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, they would have acquired a good knowledge of neurology. We are right now on Prime Neurology Part 9, Stroke Part 6, Treatment. Before we start the treatment, the stroke needs to be distinguished from potential mimics, seizure, migraine, tumor and metabolic derangements. So how do we differentiate stroke from stroke mimics? The symptom onset of stroke is within minutes, sudden, whereas in stroke mimics it is often slower onset. The symptom progression in stroke, it rapidly reaches maximum severity, whereas stroke mimics it is often gradual onset. The severity of deficit unequivocal in stroke, whereas in stroke mimics it may be variable and uncertain. The pattern of deficit, hemispheric pattern, it is usually seen on one side of the body, but in stroke mimic it may be non-specific with delirium, memory loss and balance disturbance. Loss of consciousness is uncommon in stroke, whereas it is more common in stroke mimic. And one of the common stroke mimics is hypoglycemia. So always check out blood sugar level, rule out hypoglycemia before actually starting the treatment for stroke. Because hypoglycemia is a strong stroke mimic, and all we need to do is just to give dextrose. Imaging. After initial stabilization, an emergency non-contrast CT head scan is necessary to differentiate ischemic from hemorrhagic stroke. With large ischemic stroke, CT abnormalities are usually evident within the first few hours, but small infarcts can be difficult to visualize by CT. CT or MR angiography, CTA or MRA, may help reveal vascular occlusions, but diffusion weighted MRI has a high sensitivity for identifying ischemic stroke even minutes after onset. The treatment of acute ischemic stroke. Treatment designed to reverse or lessen tissue infarction include 1. Medical support, 2. Intravenous thrombolysis, 3. Endovascular revascularization, 4. Antiplatelet agents, 5. Anticoagulation, 6. Neuroprotection. So we shall see one by one. First is medical support. Medical support. Optimize perfusion in ischemic penumbra surrounding the infarct. Blood pressure should never be lowered precipitously because it exacerbates the underlying ischemia, and only in the most extreme situations should gradual lowering be undertaken. Example, malignant hypertension with BP more than 220 by 120 millimeters of mercury, or if thrombolysis is planned, example, if BP is more than 180 by 110 millimeters of mercury. Osmotic therapy with mannitol may be necessary to control edema in large infarcts, but isotonic volume must be replaced to avoid hypovolemia. In cerebellar infarction or hemorrhage, rapid deterioration can occur from brainstem compression and hydrocephalus, requiring neurosurgical intervention. Now let's talk about intravenous thrombolysis. Ischemic deficits of less than 3 hours duration with no hemorrhage by CT criteria may benefit from thrombolytic therapy with IV recombinant tissue plasminogen activator. Based on trial data, IV RTPA is used in most centers for deficits of even 3 to 4.5 hours duration. The administration of RTPA for acute ischemic stroke. What are the indications and what are the contraindications? The indications are: 1. First, there should be a clinical diagnosis of stroke. Onset of symptoms to time of drug administration should be less than 4.5 hours. CT scan showing no hemorrhage or edema of more than 1/3 of the MCA territory. Age more than 18 years. What are the contraindications? Sustained BP more than 185 by 110 millimeters despite treatment. Bleeding diathesis. Recent head injury or intracerebral hemorrhage. Major surgery in preceding 14 days. Gastrointestinal bleeding in preceding 21 days or recent myocardial infarction. And how do we administer RTPA? Administration of recombinant tissue plasminogen activator. IV access with 2 peripheral lines. Avoid arterial or central line placement. Review eligibility criteria for RTPA. Administer 0.9 milligrams per kg. Maximum 90 milligrams IV as 10% of total dose by bolus, followed by the remainder of total dose over 1 hour. Frequent cuff BP monitoring is necessary. No other antithrombotic treatment for the 24 hours. For decline in neurological status or uncontrolled BP, stop the infusion immediately. Give cryoprecipitate and re-image brain emergently to see if there is hemorrhage. Avoid urethral catheterization for more than 2 hours. Now let's talk about endovascular revascularization. Ischemic stroke from large vessel intracranial occlusion results in high rates of morbidity and mortality. Patients with such occlusions benefit from embolectomy, less than 6 hours duration, administered at the time of an urgent cerebral angiogram at specialized centers. CT angiography is becoming more commonly used as part of initial imaging protocols to identify these patients rapidly. CT or MR perfusion can identify a subset of these patients who benefit from embolectomy even up to 24 hours. Antiplatelet agents. Aspirin up to 325 milligrams per day is safe and has a small but definite benefit in acute ischemic stroke. Anticoagulation. Trials do not support the use of heparin or other anticoagulants acutely for acute stroke. Neuroprotection. Hypothermia is effective in coma following cardiac arrest but has not been shown to benefit stroke patients. Other neuroprotective agents have shown no efficacy in human trials despite promising animal data. Now let's talk about the treatment of acute intracerebral hemorrhage. Non-contrast HET CT will confirm diagnosis, rapidly identify and correct any coagulopathy. Control systolic BP to at least below 180 millimeters of mercury. 40% of patients die. Prognosis is determined by the volume and location of hematoma. Stuporous or comatose patients generally are treated presumptively for elevated intracranial pressure. Treatment for edema and mass effect with osmotic agents may be necessary. Glucocorticoids are not helpful. Neurosurgical consultation should be sought for possible urgent evacuation of cerebellar hematoma. In other locations, data do not support surgical intervention. So these are the wonderful concepts of the treatment of stroke. The other important concepts of clinical neurology, I have put it in a book called Exam Oriented Clinical Neurology, written by me, Dr. Sreenivas, published by White Army. This book will be very useful for students appearing for clinical neurology exams. The other book I have written is Focused Neurology, which contains all essential theoretical parts of neurology, theoretical points of neurology. This book, Focused Neurology, written by me, Dr.Sreenivas, is published by CBS Publishers and Distributors. This book will be useful for students appearing for oral exams and Viva OC. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said, there are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. If you have enjoyed listening to this video, Please share, like and subscribe to my YouTube channel Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my FB page Dr. Sreenivas Concepts. Thank you. Bye.